Hello, everyone. Welcome to today's Prevention and Wellness series. We have three wonderful panelists with us today to cover new diagnosis, what's next. This will be a great conversation to hear a little bit about what happens after new diagnosis and to answer some questions. So we're really excited to have our panelists here with us today.
Y'all, as Lauren said, thanks for being here. Could you each give us an introduction, tell us a little bit about yourselves and your role, and where you work?
Who wants to go first?
Yes, you go. You've already talked.
Ladies first. Ladies first, I insist.
Well, I'll go first. That's fine. My name is Tommy, and I am a nurse navigator for Bon Secours St. Francis. I've been in this role for about 10 years now. And most recently, I'm specific to lung cancer, but I've had my hands in a little bit of everything solid. So not as many hematology or blood cancer, but specifically lung the past several years. What else can I tell you?
Charlene.
Hi, everybody. I'm Charlene. I am also a nurse navigator. I work on an off-site campus, more in a rural area. I've been doing the navigational role for about 4 years, but I've been a nurse for 23. I love what I do. I love my patients. And thank y'all so much for having me on this panel.
And my name is Jason King. I'm the assistant nurse manager here at the Prisma Health Cancer Institute, Center for Integrative Oncology and Survivorship, and Center for Cancer Prevention and Wellness. I've been a nurse for about almost 30 years now. 22 of those years have been in the field of oncology. I was a chemotherapy infusion nurse for about 9 years before coming over to where I work now and in this leadership role, but I help with the day-to-day operations of our clinic, and I oversee nurse navigators in their day-to-day duties, and also our social workers, dietitians, and stuff like that. We have a multidisciplinary team that we're over. So, yeah.
Awesome. Thank you all so much for those introductions. We'd love to hear too if you have any specific experience in things like nutrition or lifestyle medicine, maybe exercise, physiology, anything like that outside of what you would normally expect.
And I can go if so part of my role here as a nurse manager, I'm also over our oncology rehabilitation program known as Moving On. That also incorporates our exercise navigation and our lymphedema management program. And we also have, as I mentioned before, we have dietitians on site for the nutrition component, and those are free visits for patients because we don't want any barriers to patient care. But our oncology rehab program we have is also free here at Cancer Institute at Prisma for patients who have completed their therapy. It's a free 12-week program for patients. But also we just talk to patients about, we kind of meet them where they're at. They don't have to be completed with therapy. Certainly we can do prehabilitation or navigate them to other exercise options in the community. We've worked with our local YMCAs to get Live Strong at the Y, which is a grant-funded program. So that's also free for patients at any of the Greenville area local YMCAs. They just have to call up or send in an electronic interest form. And get clearance from either their primary oncologist, nurse practitioner, or their primary care provider to participate in that. So that's kind of what. And then we also have here, I should mention, you mentioned lifestyle medicine. We have 6 nurse practitioners, and 4 of those are lifestyle medicine certified.
Awesome. Thank you. Does anyone else want to jump in with any other training, other areas of expertise, anything like that?
Cool. Okay, so something we're going to talk about is the big cues, the big things that come up. We know that when you're first diagnosed and someone hears, I've got cancer, it can be unbelievably overwhelming. You kick into fight or flight and trying to digest so much information really, really quickly. What are the first 2 or 3 things y'all would encourage a new patient to do after that first initial diagnosis?
I can tackle this one just from my personal experience. I usually recommend the first thing I talk about with my patients is what kind of support system they have in place. Um, occasionally you run into patients who are maybe alone in the area, live alone, and don't have that support system. And I consider it one of my jobs to put them together with people who can help them throughout this journey, because cancer is not something that you can fight alone. And so really rallying their friends, family, support groups, clubs, churches, any support they can get around them. And it's hard for people, I think, to ask for help or even to accept help sometimes, but I encourage them that this is their opportunity to give those people a chance to do something good. It makes us feel good to help people. So it's an honor and a gift to their family and friends to be able to step up and help them through this.
I agree, Tommy. A lot of times I try to fill out where are they with their diagnosis. They've just got it, or they seem to be quiet, or they, talkative, are they getting the information? Sometimes you hear cancer and everything else just goes over you.
Yes.
So I'm like you, I feel like that. I'm like, how are you? How are you feeling? How are you, you have questions, how are you feeling about your diagnosis? I offer counseling right out of the gate for them. And I'm like you, I do encourage faith and family for sure. And I ask them, where are you? And try to tell them I'm here to plug in on those areas that maybe, they need the help.
Yeah.
I try to encompass a lot and give them some information and write down some of the things that they say, the doctor, as they go, because they are getting so much in that visit.
Yes.
Yeah, I think to Tommy and Charlene's point, it's an overwhelming time when someone's diagnosed. And it just varies as to how they get into the system, so to speak, as to when they were diagnosed. Was there was it an accidental finding? Did they come into their, say, primary care physician and with some kind of symptoms, and then they referred, to an oncologist or what have you, or they had imaging or something that showed? So it's a very overwhelming time. There's a lot of appointments, and really it's the time to, lean on the nurse navigators. Most systems have nurse navigators now, or collaborative nurses, and they're there to help guide your treatment, to help answer questions for you. Um, and you're going to a lot of appointments in a short amount of time, and meeting a lot of people. So I encourage patients to keep a notebook and write things down. Certainly if they have a family member. If they don't have a family member, as Tommy mentioned earlier, that happens a lot.
Yeah.
Find a care partner, just one of your friends, and you can have a care partner and just help. You need someone. Some people need someone usually to help them kind of, navigate that journey. So, but nurse navigators are great at that, and they love doing it.
To your point, Jason, I think a lot of people have questions about who might be a part of their care team, who would be their care team, and then what role does each person have in their care. So I would love for y'all to speak to that a little bit.
Yeah, definitely. It's going to be different. Again, how the patient enters the organization, or, say how they were diagnosed. So for example, here, patients come, we have a multidisciplinary clinic that meets. And so instead of like but some patients still have this happen, but we try to have the patient come in for one visit where they meet their medical oncologist. If they're going to have to see a radiation oncologist and a surgeon, the same day, We have nurses that are there, of course, seeing the patients, nurse navigators, and we have nurse navigators that are disease specific. So whether you have breast cancer, colon cancer, lung cancer, those nurse navigators work with those patients as you come in. So those patients are seeing all those providers in a 1 hour visit, which makes it really it can be overwhelming, but it's very efficient in that the patient's not having to see this medical oncologist that we're referred to, and then they have to wait 2 or 3 more weeks to see the radiation oncologist, and wait 2 or 3 more weeks to see the surgeon, because there's a lot of anxiety, of course, that happens during that time of diagnosis. So we try to, kind of simplify that for the patient. And again, those nurse navigators are working with the patients to guide them in their treatment, to do a soft handoff to whatever office they're going to. Again, that's not going to be the same in all organizations. I think a lot of organizations are moving in that direction. I can let Tommy and Charlene speak to their, but just along through the cancer continuum, it just depends to the course of treatment. Some patients won't need radiation, some won't need surgery, some will, depending on your diagnosis. Some might need stem cell transplant down the road. So you can have everyone from the physicians, nurse practitioners, physician's assistants, surgeon, nurses, nurse navigators, going into physical therapist, occupational therapist, speech therapist. It just depends on the diagnosis and kind of the treatment route. But I'll let the others talk about that as well.
Can I ask you a question first before the other girls answer? The other ladies answer. Is it fair to say that there's one first appointment where perhaps your surgeon, your medical oncologist, maybe your radiation they're all coming in to meet with you in that first 1 hour meeting? Is it a fair statement to say they have a pretty good plan? They have a pretty good roadmap laid out when you walk into that first appointment, so that each piece of that puzzle, each provider can kind of speak to their, how their piece fits in the patient's
Yeah,
so that,
exactly. And
right. So that patient, that first initial meeting is, we got a good plan. Here's kind of laying the roadmap for that patient. So there's, it should satisfy a lot of, not satisfy, but it should ease a lot of those initial stresses and concerns about what happens next in that first appointment.
Yeah, some physicians have met prior to this visit as well, because we have meetings beforehand to discuss the actual patient's diagnosis, and if they have had any imaging before, they're talking about what will be the best course of action for this patient. But then again, the physicians are going to talk with the patient and the family, and this is what we recommend. Most recommendations are made on national guidelines for the treatment of their cancer that they have. And that's going to say whether they need chemotherapy and how much, and which one, and what recommendation. Do they need surgery? Do they need genetic testing first to help guide that surgery? Based on their diagnosis or different studies they've done. But again, they're going to say, "This is our plan. Do you have any questions?" Also engage the patient. The patient can also be their own patient advocate. One thing that, and we may discuss this later, but second opinions is not a bad thing. If you can go to this appointment and you can have all this, and it can be, again, a lot of information and overwhelming for the patient. The patient still has the option to get a second opinion from somewhere else. Do I think we have great organizations that deliver great care and under great guidelines? Yes, I think you can get very good treatment. I don't think you have to leave Greenville, or the surrounding area to get good cancer care. We have it here in Greenville between all our organizations. But it's okay to go to another place like, MDC, or MD Anderson rather, or Emory in Atlanta, or Duke or something, and get a second opinion. The doctors are not going to be offended if you ask that. They'll encourage it if you ask for it. So just know you can be your own patient advocate, but you also are going to get good care.
Charlene, what's it like at over at Gibbs? Tell us a little bit about who
We
they
have a lot of,
meet and how all of that happens.
well, I was going to say we have a lot of the great programs that Jason has also, touched on. I feel like that every organization within our state or upstate does a wonderful job. Our doctors are up front, like the MPC meetings that we also have to bring all of the specialties together, discuss that case, make sure that we are providing the most updated, accurate, and safe care for that patient that is available. We do a lot of clinical trials to better the outcomes for patients now and later. I feel like that our doctors sit down and do a very good job with explaining things. But as my role, I'm always, after they leave, after the doctor steps out, what questions can I answer for you? Like you said, it's very overwhelming. You meet a lot of people in a very short amount of time, and it can get confusing on who's who, who's doing what, where's my appointment, what am I doing this for? So I feel like that those first interactions mean a lot. And I'm like Jason, it's never a bad thing to ask for a second opinion.
Tommy, tell us about Bon Secours St. Francis. How do those first couple of appointments and interactions look?
To piggyback off what Charlene said, I do tell patients I'm an extra set of eyes and ears.
Yeah.
That's probably my most important role.
Yeah.
I can't do anything to make this process any easier. It's still going to be a difficult journey, but I try my best to make it less complicated.
Yeah.
And so part of my role is to try and take some of that, some of the questions, answer as many questions as I can. It takes some of that guesswork in this whole process out of the process. So I like to get involved as early as I can. We get referrals as soon as a patient finds out that they have a positive path or a diagnosis. And then I help them understand the role of each provider they're going to see. So they're more than likely going to meet with a surgeon, and they're more than likely going to meet with radiation oncology and medical oncology. And why do they have to see all of these different doctors to try and help them understand the role and how these providers all work together? And then just like I said, to be that extra set of eyes and ears, because it is so overwhelming in the beginning. You're just inundated with so much information, and I know very few people that could walk out of that first consult and remember everything they were told.
Yes.
And so when I can, I like to be in person for those initial consults, just to help catch anything they might have missed and to be able to answer those questions when they get home and say, hey, did we talk about this? But our process at St. Francis or at Bon Secours in general, looks a little bit different. The navigator gets involved right away, sometimes even before the biopsy. We find out about these patients and try and help them through that staging workup where they're getting a biopsy and help them understand what the biopsy is going to tell us and being there to help, through that process of waiting for that information to come back, and what can I as a patient do while I'm waiting and in this stage. And so I try and help and be there for that process too. I do think those early days are difficult when you're just processing this information and this, big life change.
And thinking about that waiting, this may be an impossible question to answer, but I'm going to ask it anyways. What is a typical being the hard question there, the hard word there. What does a typical timeline look like? The waiting is oftentimes the worst part to start. So what is that, say I'll use part of my dad's story as an example. My dad was diagnosed because of an accidental discovery. He broke his arm. And then we waited and we waited a couple of days, and that was so difficult. What does it look like, perhaps after you find something, say you get the phone call, or say you even see it in my chart before you've heard from anyone, thinking about those things. Tell us about, like, okay, we have a diagnosis, or we know it's cancer. We're still trying to type it and all those things. Tell us how quickly things happen, I guess, is maybe a better way of asking that question. When can they expect a first appointment or a second appointment to do mapping for radiation? Or tell me more about that. Jason.
Anybody want to go? Can y'all hear me?
Yeah.
Yeah.
Okay. My audio went out a while ago, just making sure. So I know I can just speak, of course, for Prisma. I do know it's going to vary greatly. I mean, it depends again on how the patient was diagnosed, but we try to see patients within a week or a week and a half or so to appointment, because we know there is that anxiety and we want to try to get patients in. And then, it's going to take, depending on what's going on, what imaging needs to be done, what tests need to be done. For example, if this is a breast cancer, that's been found, does the patient need genetic counseling first to help guide that treatment decision to see if they have like a genetic mutation? We keep urgent slots for those available here. And we actually, going back to our multidisciplinary clinic visit where they see all those physicians or providers in one visit, we actually keep them open to where on the clinic days they're seeing them. If they think, oh, well, this patient needs genetics, we have urgent slots available for those patients. So typically things move fairly quickly. And also, time to serve. The patient needs surgery. We try to get those surgical patients in fairly quickly too. And I will mention too, some of organizations that are part of, they have what's called accreditation standards, Commission on Cancer Accreditation or National Breast Cancer Centers Accreditation and APBC accreditation. We have certain standards that we have to meet to maintain those certifications too, which works in the favor, of course, of, our patients, in that we have to reduce that time to surgery and reduce those wait times. And so not only is like a process improvement, but it's also beneficial for the patients and that it decreases the wait times. Again, and I'll let the Tommy and Charlene, discuss. It's going to vary just depending. Sometimes you have to wait for tests and you have to wait for imaging, and there's little snafus that may happen along the way, but we do try to make things happen pretty quickly.
I agree. It does vary greatly on the disease site too, or the type of cancer. Some of the more aggressive cancers, we know we've had to act immediately, but some of our cancers, it's better to have all the information up front before you bring these patients in and start going through all the what ifs. And so we do try and get those, to get the staging done so that the patient has not only do they know what type of cancer they have, they know what subtype of cancer they have. And some of the testing for genetics takes a little bit of time. But it is beneficial to have that information up front too. The outcomes have been shown to be much better if you start those targeted therapies and immunotherapies, and that information has to be gathered before you can begin treatment. But I find that with most patients, and this again is one of my biggest roles, is that if I can be there with them along the way and help them understand why there's a couple of days delay, why this treatment is dependent upon this test, and that it's not wasted time. They as long as you communicate with them and they understand what's going on, most of them do want, obviously, to get all the information up front, so they understand that some of these delays are necessary for test result. But it is a scary time to feel like you're just sitting and doing nothing. So if I can be there for them and help them understand along the way that we're working in the background. There are things being done and things taking place during that process.
Yeah, I agree. I know from the scheduling standpoint where I am, a lot of times patients are very anxious. They hear the C word and they want to know something. So our turnaround time, like everybody else, is very some, but we do try to get them in as soon as possible to talk with our medical oncologist just to discuss what we have and what our next steps will be. A lot of times patients are like, okay, I need this, or when can I do this, and when can I do that? Just to answer some of those upfront questions. Even though we may still need some more imaging or a biopsy or things like that, it's, to get them in to say, hey, I'm here for you. This is what we're going to do from here. This is why we're going to do what we're doing. That way they can get that little peace of mind and say, okay, I've got a direction now. Because before I'm sitting there going, I don't know what I'm going to do. I don't know what's next, blah, blah, blah. So I'm like, y'all, it varies as far as getting from point A to point B as far as diagnosis, treatment, and a plan. But just trying to talk with them up front as fast as you can to alleviate some of those anxieties. To say, hey, okay, this is what we know. This is the way we're going to go. This is why you need this, this, and this. And being on that first visit is, to me, very crucial for a navigator to give you that information, my number, my email, make sure, are you set up on my chart or whatever system that you go to, whatever they have, but go to that my chart or everywhere, so that way you can see what's going on, keep up with your appointments more, and just to find out, are they literate or not? Can they read? Do they have disabilities as far as learning, or are they not understanding health terminology about their disease and stuff? A lot of times that can help right out the gate.
Yeah. And then this last big one is a open-ended too, is where, a diagnosis and how where you might receive that diagnosis can impact the trajectory of when, who, why, and what, thinking about if it's an accidental discovery, or perhaps if you're inpatient versus outpatient and how those things impact navigation through a new diagnosis too. Can you tell us a little bit about the difference between the two? If, perhaps even like different hospital locations too, thinking about different campuses and things like that, where they might be receiving treatment, if it's at each of your cancer centers, if it's at a different location, all of those impacts. Yeah, tell us a little bit more about, I guess maybe let's start inpatient versus out, how those things differ from each other. And then maybe for outpatient, let's take a look at your different locations and how that can impact a care plan too.
I think if you're just starting with the inpatient, typically if you're inpatient and you've been diagnosed, it's probably an incidental finding potentially. You know, just like you shared earlier, your dad broke his arm and that's how they found his cancer. So, and that could have been like, an outpatient ER visit, but I would think probably inpatient's probably more incidental finding, or they came in for surgery, opened the patient up and found, they had cancer, and then started the process from there. And I think naturally, if you're inpatient, things are going to flow a little quicker because you're going to have imaging and diagnostic studies right there inpatient. You're going to have consults for whatever oncologist is on call to get those things rolling. So things may flow a little quicker that way.
Yeah, we are primarily at one campus. We have, obviously the cancer center is not located at the hospital. So when patients are diagnosed inpatient, I've dedicated a couple of mornings a week, and each of the various navigators have done this, where we try to go and meet those patients inpatient when they receive their diagnosis. A lot of my patients wind up being diagnosed. For example, if it's GI or lung, a lot of those come through the emergency room. And so they came in, had no idea what they were about to find out, and then received this diagnosis. And so I like to get it, back to what I said earlier, I just like to get involved as soon as I can. And so I try and meet them there, explain to them how they're going to transition to the outpatient process.
Yeah, at Gibbs, we have both. We've got inpatient and then we've got some outpatient facilities. But with Jason, it usually moves a lot quicker if they are inpatient. Just to say, if they're inpatient, it seems like they can get started sooner with everything, as opposed to outpatient. Although I think outpatient, I think our facilities do very well to get them in as quick as they do. But I believe that inpatient does move a little bit quicker, but outpatient does a great job as well.
All right, moving on to a little bit of a different topic, but kind of tied into what we've been talking about. A lot of information gets thrown at patients when they're first diagnosed. So what are some helpful tips, tricks, tools that people can use to keep track of all this?
Yeah, I'll have some listed here. Actually, yeah, the example is MyChart. I think a lot of organizations have moved to MyChart, which is, used for, you can go in there and look at your medications, whether that's your primary care physician, as long as they're in that same system. You can look at imaging. Now, I will say that if the patient has some type of imaging or if something that is sensitive, I believe the providers have the option to not to mark it as sensitive to where they have time to review it before that just goes out to the patient.
Yes.
And also some providers also can mark notes as sensitive. Let's say a social worker who does one-on-one counseling and that patient has divulged something that's very sensitive to them and they don't want just that anyone in their medical record can read it, then that provider can choose to mark that note as sensitive, so others cannot see it and it stays with that one provider. But as far as like tracking, definitely MyChart, notebooks, the care partner, as we mentioned before. There are applications now. There's so many, I won't name one, but there are different apps that will help track things as far as like appointments and things to follow up on, medication tracking, stuff like that. There's a lot of things that many of those have been created by some of our industry partners or those we get the medications for the cancer therapy from. So there's a lot of things out there.
Yeah, that's true. There are a lot of helpful tools now, some apps that are available to help patients keep track of all of that. There's, I find that in my population, a lot of them are elderly, and so oftentimes they don't use MyChart, they don't use smartphones, they don't use their laptop, or their family members oftentimes step up and help them with that. So when I walk into a patient room, appointment, I still bring a notepad, a business card, and a folder. And I hand that to them the first day and say, "This is your folder. Keep everything in it." I make sure they have a notepad to take notes. But most importantly, I give them my contact information and say, you're not going to remember everything we talk about, and there's no such thing as a stupid question. I don't have all the answers, but I know where to get them. So feel free to call me if you get home from this visit and think, "Did we talk about that?" Or come up with questions we didn't talk about. That's one of the reasons that we're here. And it's not just navigators. We've got a lot of support for patients. We have a chaplain on staff that's here in the center every day. Our social workers, nutritionists that are here to help answer those questions.
Well, I don't know about a lot of my patients, but I'm one of those that I like it written down in a couple of different places just to keep me on track. I encourage my folks to ask for a printout of a calendar that's got their appointments and where they're going and what day. To me, visually, it's a lot easier because I'm like, Tommy, I've got a lot of folks in my area that they don't do so well with a smartphone, and they, don't remember their passwords. They can't get in, and they just don't like it. It's frustrating to them. So I encourage all about the printed out AVS after visit summaries with their appointments. Get a calendar. We'll print you one out, and it has all your appointments up to, the very last one that's been made. And if you need another one, stop by the office. We'll be glad to print you out another one if you lose that one. But keeping track is very important to try to keep them on point with their appointments, treatment schedules especially. And it's always good that they have your number, because a lot of times they will call me to say, hey, I need to change an appointment, or I can't make it. Can y'all call me and let me know when I can? So putting those messages in, and trying to keep track of, what their needs are and where they are, make sure they get rescheduled. So I'm one of those that advocate definitely for my chart, but my population, a lot of them, like you said, flip phones, get frustrated with the whole computer part of it.
From my own experience, something that my family did when my dad was inpatient and outpatient, when he was inpatient, especially, I have two siblings and my mom, we all kind of took turns being at the hospital with him day in and day out. And for those days, something that we did that was really useful was we had a shared note app on our phones, and we did it day by day, hour by hour. Every consult that came in, every blood pressure taken, every medication administered, all of it, which was probably overkill, but it made us all feel better. And then my dad being the flip side of that, where he's a paper calendar guy. So he liked to be able to see the printed calendar of all of his appointments, and when he was going to radiology, and when he was, all of those things were immensely helpful for his peace of mind. So we did it both ways. But yeah, the notes app was our favorite tool to keep track of all the things.
It's a good idea.
Yeah. Okay. The cost of care. So, I mean, we've touched a little bit on this, but the cost of care is financial, but it's also, the emotional burden of care, whether you're the patient or the caregiver. Can y'all tell us a little bit about the financial stress side of it? A little bit more about how y'all help patients navigate insurance and billing departments and all of those types of things. Is that something that y'all as navigators have a large hand in, or is that something that perhaps someone else in the care team might help a patient with?
Well, at Gibbs, we also, we, find out if they have insurance or coverage. A lot of times if they, are diagnosed and going through treatment, they're unable to continue work. And a lot of times they'll lose their insurance. So we do assist them in trying to get another insurance on board, get them applications to fill out. I help facilitate those, get any notes, doctor signatures, things of that nature that they would need to try to qualify for these programs. If all fails and they're not qualified, for whatever reasons for certain programs, we do have a program, JFCC, at our hospital system that will pick up the oncology tab for these folks so they can continue to get the coverage that they need. A lot of times co-payments are a big deal. They are some fund out there for co-payments, depends on disease specific. On co-pays, there are a lot of foundations out there. I try to give them opportunities to look at those, call those. If they need help with that, I will be glad to do that for them on their behalf. So I do apply a lot for grants for my patients, for the financial reasons, gas, automobile, just the wear and tear of having to go every day to radiation. That's a huge burden on a lot of patients, having to go daily and driving. My county goes out as far as York County, and that's Blacksburg. That's a big drive to Spartanburg to do their radiation and stuff. So I'm in it with both feet a lot of times with a lot of patients to do those applications for them.
Yeah, and I think just to Charlene's point, navigators are the point that connect you to whatever a lot of the patients need. So whether they're helping like Charlene does or Tommy does, there also can be financial navigators in the facility that they can connect you with. I know here at Prisma, we have our social workers who work very one-on-one with patients. We'll refer them for financial navigation. They have, again, like Charlene mentioned, a lot of different grants that they know that open up, and those tend to open and close very quickly. So you have to kind of be on the ball with those. And sometimes they're for specific diseases versus any, but it just varies. There's different things that are opening and closing all the time. One thing that the our social workers do and is in the community is our neighborhood cancer connection that supports all of the Greenville area, and they can help with certain things. They can help with paying like a light bill. They might help with a little bit of mileage for going to appointments. They can help with nutrition. I know it's a little different from financial, but it's still, if you're paying for other things, money goes and you need money for different things. So there's different resources in the community that's both your, whether it's your internal partners who help or your external partners. And we try, the one thing with the nurse navigators is they know those connections. And so they're trying to connect those patients to those resources. Some organizations, like Jarlene has a fund, we have what's called here hospital sponsorship for patients, and the patient just has to meet typically a certain criteria. Many times that's for uninsured or underinsured individuals. But again, it's based on need and it's based on there's certain criteria they meet. But we connect them with those services here in the hospital and see if they can also benefit from those.
Yeah, one of my first conversations with my patients, I tell them, "You just met me, and I'm about to ask all the nosy questions." But the reason for that is I try and get a good feel for the financial stress that they're already experiencing. Most of these patients are already getting medical bills by the time they get here for various tests or imaging. And that really does make a difference for people as they go forward when they make decisions about their treatment. Unfortunately, they have to consider that financial piece. So I tie all of my patients in with the Neighborhood Cancer Connection as soon as we find out that they're going to go through a treatment. And we do have social workers here, so they assist with those things like financial assistance through different manufacturers or financial assistance through the hospital sponsorship. And then we also have financial navigators or counselors here that are involved in making sure that all the costs are covered for treatment or assistance with co-pays. So we approach it from several different support groups.
Yeah, cool. And then to the emotional side of it as well. So I imagine that you can all refer out to social workers and chaplains and folks like that can help with those things. And something too I'll touch on as well that is a huge part of it is the caregiver, too, is making sure that they're well taken care of as well. And that it's important that they can do their job well as a care provider, and part of that is trying to help them emotionally cope with a cancer battle as well. Does everyone have chaplains on campus? I think Tommy mentioned that. Everyone. Okay.
Mm-hmm.
Okay.
Yeah. And so is that something in the purview of a social worker at all of your systems as well? The emotional toll and perhaps connecting them with outside resources for that sort of, okay.
We have counselors, therapists here at the center. And that's a service that's available to them. And then there are lots of support groups in the area. We have one here at the Cancer Center, but there are a multitude of support groups in the Upstate.
Yeah.
And then, our chaplain is always here and available. But I think it's important that we assess that level of stress for the caregiver too, because oftentimes they don't want to be a bother themselves, and they're so focused on their family member who is the patient that they say, "Oh, my problem is small. I need to worry about them." But oftentimes they don't even want to admit that it's difficult. That's they feel guilty about that. But Yeah, I've had personal experience with this, and even when you think you're handling it all well, there's still a level of stress there that affects you physically and emotionally, no matter how well you're coping. Just the physical toll, the stress, the loss of sleep. So the most important thing that I can do in my role, I'm not a counselor, but I can certainly talk to them and get them to open up about that and let them know that we're there for the families and the caregivers as well. We have lots of support for them also. Uh,
Absolutely. And then that, y'all have already touched on NCC, Neighborhood Cancer Connection, and their resources, both financially and emotionally. What about other organizations with resources in the upstate that y'all connect, provide, caregivers or patients with? Who are some heavy hitters that often y'all see the need for in a new patient?
So one I know, Cancer Association of Anderson County is another we use because all the organizations were kind of centrally located in a way, and Spartanburg are kind of like the outlying Greer areas and stuff. But like, so you have organizations both in Spartanburg and Anderson and here right in Greenville. So I can't remember the the Spartanburg Cancer Association at the moment.
It's just Cancer Association of
Of
Spartanburg.
Spartanburg. Okay.
Yeah.
Yeah. So we all, they all work with all the local organizations here. So that's, one of all three of our external partners. So including, Neighborhood Cancer Connection. So, and they can do different things. Naturally they get money or funds each year. And so they can be limited as to what they can do, but they can typically do, something related to helping with costs of transportation, or helping with cost of maybe like a utility bill, nutrition support, and counseling, or if they have support groups and stuff like that. So most of them all have that same supportive ability.
Yeah. Oftentimes they even have prescription reimbursement or programs to help with
Hmm.
cost for prescriptions too.
Mhm.
Yeah.
Yeah.
Um, and I give my patients the 1-800 number for American Cancer Society.
Yeah.
We have lots of volunteers that are, happy to spend time talking to you about what's available out there. And then I give them your names and numbers at the
Shameless
cancer.
plug.
I give them the website so they can find events because I had a patient tell me years ago that it's nice to sometimes just not be a patient and not be treated like a patient.
Hmm.
So they want to get out and do things that create a sense of normalcy as much as possible. And so there are support groups and programs in the area that do that are just there for fun things to. Um, they're under such a financial burden and the stress on their family, their finances, their time that there are organizations that are out there to help with that.
Yeah. Cool.
All right, so just some final thoughts and comments. I'd love to ask each of you your one piece of advice. So someone who's newly diagnosed, what's kind of one take-home message? And I'll actually start with Kelsey.
Yeah, we touched on this on that first slide. Mine is, being your own best advocate. I think, that's kind of how CSPA came to this topic for prevention and wellness is um asking every question. Don't assume anything is a bad question. Um Ask for a second opinion, ask for an insurance appeal, ask for, all of those things that you one may not be aware of, but two, in every situation, if you have a question, it's always worth asking. Even at the end of it, it's just peace of mind. I would always suggest asking the question for yourself as if you're a provider, or for yourself as if you're a patient. Um, yeah, I mean, I in my own experience, I found that it was a huge thing it was something we definitely grew into to learn to ask those questions. And it's not something that comes naturally at first, but it's definitely it definitely pays off once you get the courage to ask all the things. So that's my piece of advice.
Yeah.
I would agree. That's what I was going to say is be your own advocate. You education is empowering. And so, oftentimes patients feel like they have no control over what's happening to them. That, this disease takes everybody by surprise, and it's almost like you have lost control of what your body is doing. But a way for people to regain some of that control is to educate themselves and find good resources out there to do your research. Ask the question. There's no such thing as a dumb question. If you've got that question, I can guarantee you that one of us has either asked that question before, or there'll be somebody coming down the road to ask that question tomorrow. It's just so important to be your own advocate, and we're all there to support you, but sometimes people have to ask for support.
Yeah.
And we have to understand what your needs are. So it's so important that people open up and let us know that too.
Yeah, one thing I would say, a bit of advice would be, we know as clinicians, when you come in, you're carrying more than just your diagnosis. We all are human. We all have responsibilities. We all have, say, baggage, so to speak. We have, our lived experiences. So I think what nurse navigators are really good at is trying to really get to know that patient and where they're coming from and meeting them where they are. And sometimes those patients will open up, and sometimes it's a little bit harder to crack the nut, to see what they need. But as you build that rapport and that relationship with the patient, I think, nurse navigators are, they're a great resource to guide you in your treatment and care. And they're more than happy, like Tommy and Charlene says, to answer questions. So just know that we know that you're coming in with all of life's struggles, even before, the diagnosis. So I will add one more thing too. I want to mention, going back to just treatment in general, just this is the former infusion nurse coming out in me, is that don't be afraid of a clinical trial. Clinical trial is standard of treatment, plus or minus some potential benefit. So please do not be afraid if a navigator or a clinical trial navigator comes to you when it's time to talk about your therapy and say, we want you to consider this clinical trial. That is a good thing. That gives you access to, again, it's standard of care, what you would typically get anyway, but you may have a benefit. It could be another drug that's come out and it has a new indication, and this is going to be your way to get it before others would get it. And typically, and that's just a great thing for your benefit. So don't be afraid of clinical trials is my other piece of advice.
Well, my advice to anyone is stay communication. Don't be afraid to call my chart, ask those questions, connect your doctor with my chart. Say, I'm not feeling well today, or I'm having a bad day, or this, that, or the other. I also encourage my patients to try to stay positive. Don't just be a couch potato. Keep living, keep going, keep doing as much as you physically can. Try not to let this slow you down. I know you're going to have bad days, but if you can, stay positive, keep your faith. And, I always like to, tell them that if they have nobody that they feel like they can talk to, family just, telling them this, that, or the other, I'm always available. I'm no counselor, and I tell them I don't know everything, but I can get you to somebody that does know something about what you need to know. But if you ever want to talk to me, that resource, that openness, that line is there. And I've had a lot that you just sit there and say, yeah, or just nod, just so they can talk. But yeah, mine is communication. And if you're having a bad day, just tell them I'm having a bad day.
And this goes back to what both of you have said, but Jason, you talked about trials and that sort of thing. I also encourage patients during that treatment decision period, speak up.
Yes.
You know, it is ultimately your body and your decision. Nobody can go through this for you. You're the one going through it. So speak up if you don't like something that we're proposing. If you're not in agreement with something, that's, you know,
Agreed.
there
Yes.
again, that's where your advocates are there for you for that reason. If you don't feel comfortable saying it, then let one of us know. We'll say it or ask it for you.
Yes.
Cool. Anything else?
Yeah. All right. Well, thank you so much to our panelists for being here today to discuss this topic with us. I think this has been a lot of great information. I want to highlight next month's prevention and wellness topic. Gibbs will be back to talk about oncology rehab, so we're looking forward to that. And Elsie's going to close us out with a quote.
Yeah, we always close out with a quote. This one came across my desk recently and it seemed very fitting. Take the first step in faith. You don't have to see the whole staircase, just take the first step. And that's Martin Luther King Jr. Thank you all again for doing this. This was so helpful. And we hope to see you again soon at the park. Thank you all.
Thank
Thank
you.
you.